So this week we will be discussing the clinical concepts of community acquired pneumonia. Pneumonia on the whole, but I'll start with community acquired pneumonia. So today what we are going to discuss is we will see the clinical concepts of pneumonia. So what exactly should be kept in mind when you are treating? Clinical concepts of pneumonia. First we will start with community acquired pneumonia. So then we shall dwell into nosocomial pneumonia. So this is the recent classification. We have only two, community acquired nosocomial. Again nosocomial, non-ventilator pneumonia called as hospital acquired pneumonia, and ventilator associated pneumonia proper. So coming to the common community acquired pneumonia. So we have discussed last week, community acquired pneumonia is again divided into typical pneumonia. So most common typical pneumonia that we come across will be streptococcal pneumonia. Along with that, we have staph pneumonia, Klebsiella pneumonia, and Haemophilus influenza pneumonia, H. influenza. So usually streptococcal pneumonia and Haemophilus influenza pneumonia can have similar presentation, students. So Haemophilus influenza pneumonia. But if they ask you, out of this, most common typical pneumonia is always streptococcal pneumonia. So if you see a community acquired pneumonia with the typical features, fever, productive cough, chest X-ray consolidation, and predominant neutrophilic leukocytosis, you should target streptococcus. On the other hand, a patient with fever, dry cough, no significant chest X-ray infiltrates or only interstitial pattern. So that is atypical pneumonia. So what we come across most commonly is mycoplasma. We have Legionella, chlamydia not that common in our setting, and a variety of viral pneumonias. And once again the same question, most common atypical pneumonia, answer should be mycoplasma. So what we are going to do is, we will discuss 5 pneumonias today. So we will see streptococcal pneumonia, staph pneumonia, Klebsiella pneumonia, mycoplasma pneumonia, Legionella pneumonia. Whereas viral pneumonias, the scenario has completely changed due to the COVID pandemic. So I'll have a separate class on viral pneumonia discussing both the influenza and also COVID-19 next week. And mostly Haemophilus influenza and the streptococcal pneumonia can have similar presentation and treatment is the same. So first, in community acquired pneumonia, a patient is coming from the community, he is having pneumonia, see whether it is a typical pneumonia or atypical pneumonia. And depending on that, you can suspect the organism and have the treatment. Now first, the differentiating features of streptococcus, staph, Klebsiella. So I'll put it at a single place like a table so that you will know the comparative features. So streptococcus, staph, Klebsiella. So we will discuss what are the important risk factors and what will be the specific clinical feature. I will not discuss the common clinical features. The common clinical feature for any pneumonia is fever, cough, shortness of breath, chest pain. We will discuss specific clinical features and what do you expect on a chest X-ray, and what is the usual treatment regimen. Coming to streptococcal pneumonia, as discussed earlier in etiopathogenesis, we know smoking can increase the chances of streptococcal pneumonia, and streptococcal pneumonia is most common pneumonia also seen in diabetics, alcoholics. Most common pneumonia in a diabetic patient and also alcoholic patient is streptococcal pneumonia. Most common pneumonia in diabetes and alcoholism. By number, it is still streptococcal pneumonia. Then coming to the clinical feature, one can notice red rusty sputum. Red rusty sputum. Now the radiology, consider this is the lung. Streptococcus can cause localized consolidation. So this is called as lobar consolidation. Lobar consolidation. So this lobar consolidation is localized involvement of lobe or segment of lung. Localized involvement of lobe or segment of lung. And this lobar consolidation is most common pattern seen in community acquired pneumonia. If at all there is a patient with community acquired pneumonia, what is the most common radiological pattern? Lobar pneumonia or lobar consolidation. And treatment for streptococcus is usually beta-lactam antibiotic. Treatment for streptococcus is usually beta-lactam antibiotic. Then coming to staph. Staph pneumonia, it is also called as IV drug users pneumonia. IV drug users pneumonia. And this staph pneumonia, it occurs as fatal pneumonia. It occurs as fatal pneumonia post-viral illness. Fatal pneumonia post-viral illness. And the clinical features, one can notice mucopurulent sputum. In staph pneumonia, one can notice mucopurulent sputum. And on the chest X-ray, what do you see is, so we have discussed last time something called as bronchopneumonia. So there will be bilateral patchy consolidation. So there can be bilateral patchy consolidation. This bilateral patchy consolidation is nothing but the bronchopneumonia pattern. So this is the bronchopneumonia pattern. And this bronchopneumonia pattern is considered as most common pattern in nosocomial pneumonia. Even though staph usually occurs as nosocomial pneumonia, in few situations it can also occur as community acquired pneumonia. So when I discuss about staph, I should tell you the other radiological features. Staph pneumonia can cause pneumatocysts. It can cause cavities. It can cause lung abscess. There can be pneumatocyst formation. There can be cavity formation, and there can be lung abscess formation. And treatment. Nowadays, by the time a patient with staph pneumonia reaches me, he is already MRSA. MRSA means methicillin resistant staph aureus. In this situation, we give vancomycin. But unfortunately, especially in the ICUs, these days vancomycin resistance has become very, very rapid. Now in such cases, the drug of choice will be linezolid, because especially in Indian ICUs, vancomycin resistance is very, very rapid and rampant. So whenever I suspect MRSA, nowadays I am directly starting linezolid, and this is a guideline followed worldwide. Because of the rampant vancomycin resistance, whenever we suspect, especially in ICU, this patient can have MRSA pneumonia, we can go for linezolid directly. Coming to Klebsiella, the risk factor, malnutrition, alcoholism. But if you want to know what is most common pneumonia in alcoholics by number, it is still Streptococcus. Klebsiella, it can happen in alcoholics specifically, but by number in alcoholics, still most common pneumonia was found to be in various studies streptococcal pneumonia. Then coming to the clinical features, this Klebsiella pneumonia has a thick coating. Because of this thick covering, sputum will be red and it will be gelatinous. Red currant jelly sputum. This phenomena is called as red currant jelly sputum. Then what do you see on the chest X-ray? Consider this is the right lung and let this be the horizontal fissure. Klebsiella causes very, very dense pneumonia, very, very heavy pneumonia. Because of this heavy consolidation, the horizontal fissure, which was straight previously, will bulge down like this. So this is right upper lobe consolidation. With the classical bulging fissure sign. See here students, for better understanding, normally your horizontal fissure will be straight like this. So whenever there is some weight, it can slightly bulge down. So this bulging down is called as bulging fissure sign. And Klebsiella is also capable of causing pneumatocysts, cavities, and lung abscess. And the treatment of Klebsiella is usually combination beta-lactam antibiotic with aminoglycoside. And once again students, all these features, don't think 100% it will exist in Streptococcus, 100% you will see it like this only in Staph, you will see it like this only in Klebsiella. See, they can also present with overlapping features. They can also present without these classical features. But if you see this together, you have to suspect it as the that organism. But definitive diagnosis for Streptococcus, Staph, Klebsiella is always culture. So if you can find the organism in culture, so that will be the definitive organism. But meanwhile, a pneumonia, you cannot wait till the culture results arrive, because if you wait, the infection can progress and patient can develop hypoxemia, sepsis, empyema, lung abscess, all those complications. You have to start empirically treatment, and depending upon the culture sensitivity reports, you can change the antibiotic. So these are the various presentations of Streptococcus, Staph, Klebsiella. Now let us see some images Now, what is the pattern seen in this image called as? So what will be the organism? So definitely, because there are this air bronchograms, it is consolidation. But if you notice here, it is consolidation localized to a lobe. So this is more of lobar consolidation. So whenever it is a lobar consolidation, and the classical presentation is of which organism? Streptococcus. So this is a streptococcal pneumonia. Streptococcal pneumonia you generally see in a chest X-ray like this. Then staph, usually with some risk factors. And this patient, what do you see here? So you see bilateral patchy consolidation. So this is bronchopneumonia. So bronchopneumonia. So patient might be some IV drug user. Patient can be having a previous viral infection, now coming with severe hypoxemia. So this is bronchopneumonia. So this bronchopneumonia is usually seen with staph aureus. So usual lobar or unilateral presentation is classical of streptococcal pneumonia. So bilateral bronchopneumonia pattern is staph pneumonia. So in all this, it is a typical pattern with consolidation and usually sputum production. So lobar pneumonia, bronchopneumonia. Now what do you see in this image? Normally the horizontal fissure should be straight like this, but it has bulged down in this manner. So this is called as bulging fissure sign. You find right upper lobe consolidation with classical bulging fissure sign. And what will be the organism? It is usually Klebsiella. So the organism is Klebsiella pneumonia. Klebsiella is also called as Friedlander's bacilli. So if you find a patient with this pattern, he is an alcoholic, malnourished, red currant jelly sputum, and on the chest X-ray, right upper lobe consolidation with bulging fissure sign. So your first suspicion should be Klebsiella pneumonia. So these are the three important community acquired pneumonias that one should be thoroughly knowing. That is typical pattern. Now coming to atypical pattern. In atypical pattern, so we are having two. One is Legionella and other is Mycoplasma. Again, there are few similar features and there are few differentiating features. So previous slide. So you want this X-rays or this slide? So this is a table and this is a slide showing the X-rays. One is lobar consolidation, other is bronchopneumonia. So these are the air bronchograms that we have discussed previously. And this is Klebsiella pneumonia, right upper lobe consolidation with bulging fissure sign. Okay. So this is a table showing three pneumonias: Streptococcus, Staph, Klebsiella, and these are the chest X-ray features. Is it okay? Have you noted this down? This theory slides table. Okay. So we'll go to important atypical pneumonias. Let us start with Legionella. So this Legionella, it is the most common cause of atypical pneumonia. Atypical pneumonia resulting in ICU admission. Whereas most common cause of atypical pneumonia overall is mycoplasma. So what is the difference? See, if you find an atypical pneumonia, it is usually mycoplasma. But majority of mycoplasma pneumonias are mild. It will not require any ICU admission. But if you see an atypical pneumonia in the ICU, most common cause is Legionella. It means Legionella generally can cause severe pneumonia. Mycoplasma pneumonias generally mild. It does not require any ICU admission. Whereas if you find an atypical pneumonia responsible for ICU admission, probability of Legionella is more. And for Legionella, most common method of transmission is aspiration followed by aerolization. And the usual reason for this is spread through contaminated water. See, Legionella pneumonia, generally there is no man-to-man transmission. Legionella stays in contaminated water. This patient might drink that contaminated water. Organisms can reach the oropharynx and later it can be aspirated into the lungs, or he inhales aerosols from this contaminated water. So contaminated nebulizer, contaminated respiratory equipment, so all this aerosols, he inhales aerosols from the contaminated water and he can develop, so air conditioners, aerosols from the air conditioner, contaminated water, so that can spread through contaminated water. Whenever we are discussing about Legionella, you should know some special features by which you can suspect it to be Legionella. So what are the special features? Along with pneumonia, there can be associated diarrhea. So Legionella not only causes pneumonia, it causes diarrhea. Because of fluid loss and CNS involvement, there can be hyponatremia, confusion, headache. All these are CNS manifestations. As a part of systemic involvement, liver can be commonly involved and there can be altered LFTs. And this generally occurs in this pneumonia. So old age, especially elderly, and immunocompromised. So Legionella is a common pneumonia even in immunocompromised. And because of some unknown reason, there will be poor response to commonly given antibiotics called as beta-lactams. So if you give amoxiclav or the ceftriaxone beta-lactams, in Legionella it will not work. And if you see an association like this, occurrence of illness within 10 days discharge from hospital, within 10 days discharge from hospital, one suspicion should be Legionella. Now what is this? Suppose there is a patient admitted to hospital with abdominal pain. Now in the hospital, he is exposed to contaminated water containing Legionella. Now Legionella incubation period is prolonged. It takes 7 to 10 days for the disease to happen. So patient's abdominal pain may subside. He might get discharged from hospital after 2 days. Now in the home, after 3 to 4 days, now Legionella pneumonia can develop because of its prolonged incubation period. It means patient can be infected in the hospital and later pneumonia can manifest at home also. So usually if it is any hospital acquired pneumonia such as gram-negative bacilli or staph, it happens within 2 to 3 days. But here, because Legionella is having a prolonged incubation period, so patient might be infected in hospital. Later the pneumonia can manifest at home also. If you find this situation, one suspicion should be Legionella. Now let us also see few salient points about Mycoplasma pneumonia. So Mycoplasma, after the name of the scientist, it is also called as eaten agent pneumonia, and it is previously called as walking pneumonia. Now what is this walking pneumonia? Whenever a patient develops some lung infection, because of the severity of illness, majority will be taking bed rest. Now Mycoplasma causes pneumonia, but it is very mild. So patient is having pneumonia, can still do his routine activities like walking. Because he is having pneumonia and has capacity to walk, it is called also as walking pneumonia. Kindly don't ask me what is running or dancing pneumonia, no such terms. So walking pneumonia is a historical term telling that in majority Mycoplasma can have mild presentation. So even though Mycoplasma is generally mild, very rarely there can be extrapulmonary features. So very rarely seen, students, very rarely seen. So where you see them? So in the skin there can be erythema nodosum, rash. Sometimes it can also progress to severe form called as Stephen-Johnson syndrome. So again this is very rare. Then in the CNS, as a part of systemic involvement, there can be encephalitis, and very rarely Mycoplasma infection is implicated in the etiology of Guillain-Barré syndrome. Very rare again. Then within the blood, Mycoplasma has tendency of some autoimmune phenomena. There can be increased cold agglutinins. So these cold agglutinins are some specialized autoantibodies, and there can be also, because of this autoimmune phenomena, tendency to cause hemolytic anemia. So if you come across pneumonia and hemolytic anemia combination, you should think about Mycoplasma. Pneumonia and diarrhea combination, you might think about Legionella. So pneumonia diarrhea combination, probability of Legionella. Pneumonia hemolytic anemia combination, probability of Mycoplasma. And within the CVS, rarely myocarditis, pericarditis. And within the joints, there can be arthritis. And one important feature of Mycoplasma organism is, for this organism, there is no cell wall. There is no cell wall. Now, how does this feature influence me in treatment? Because there is no cell wall, commonly given antibiotics such as beta-lactams will not work. because beta-lactams require cell wall to exert its function. So there is something common in Legionella and Mycoplasma. So in Legionella, because of some unknown reason, beta-lactams are not working. In Mycoplasma, because there is no cell wall, beta-lactams will not work. So for atypical pneumonia, especially Legionella mycoplasma, there is no point in giving beta-lactams. And because these are atypical pneumonias, even to see the organisms in sputum gram staining is very difficult. And culture will take lot of days. And before the culture report arrives, patient generally will not be there. Either he will be discharged or he will be dead. So that's why let it be for Legionella or Mycoplasma. So we don't depend on gram staining, we don't depend on culture. Because no cell wall in Mycoplasma, you cannot do gram staining. In Legionella, these are atypical pneumonias. You cannot get those organisms in the sample, in the sputum sample. So what will be the diagnostic method? For Legionella diagnosis, so write down, for Legionella diagnosis, we have specific urine antigen test. Urine antigen test for Legionella. Along with that, we have serological tests, so which will detect the antibodies against organisms. So if available, we can go for PCR, molecular test, polymerase chain reaction, so which will detect the precise genetic material, and you will know whether it is a Legionella or Mycoplasma. Whereas for Mycoplasma diagnosis, we rely on serology, antibodies against the organism, and if available, we can go for PCR. So samples from the respiratory tract. So you can take a throat swab, nasal swab, you can send even sputum if there is production. So Legionella, Mycoplasma, these are the investigations available for usual diagnosis. So how is Legionella diagnosed usually apart from the clinical findings? It is an urine antigen test. And Mycoplasma, we either diagnose through serology or PCR, polymerase chain reaction. So routinely culture is not reliable because it will take a lot of days for the culture reports to arrive. So this will be the difference in presentation of Legionella and Mycoplasma. So Legionella special features generally you should keep in mind: diarrhea, hyponatremia, confusion, headache, altered LFTs, occurrence in old and immunocompromised, poor response to beta-lactams, occurrence of illness within 10 days discharge from hospital. Whereas Mycoplasma, there can be presence of extrapulmonary features. Then how to treat this disease? How to treat Legionella, Mycoplasma? As I told you, in both, there is no point in giving beta-lactams. Then what should be given? So treatment, it is common for both. You can give either fluoroquinolone or macrolide or tetracycline. But if somebody asks you what is best for Legionella, so for Legionella, the best drug generally is fluoroquinolone. And that too, which fluoroquinolone? Respiratory fluoroquinolone. FQ means fluoroquinolone. So we can give levofloxacin, moxifloxacin. And for Mycoplasma, which is the best drug available, we have macrolide, that is azithromycin. So in community setting, depending upon the availability, so let it be Mycoplasma or Legionella, you can give any one of the following: fluoroquinolone, macrolide or tetracycline. But if they ask you specifically what is best for Legionella, It is respiratory fluoroquinolone. Best for Mycoplasma macrolide, azithromycin. Now we have discussed about 5 community acquired pneumonias. Now let us say, for example, you are sitting in the OPD or in the emergency department. There is a patient with the features of pneumonia. How will you assess the severity and decide whether to send him home and treat, whether admit in ward, or to shift him to ICU? For this, there is a very simplified and a practical score called as CURB 65. See, there are also other indicators such as pneumonia severity index, which contains 20 variables. So there is also SMART COP score, SMART COP score, that also contains multiple variables. So there is ATS, American Thoracic Society, major criteria, minor criteria, classification for assessment of severity of pneumonia. It is also a scoring system. So all these are not practical and not very easy to apply. So for all practical purposes, whenever there is a patient with pneumonia, community acquired pneumonia, so you should go for CURB 65. So C for confusion, U for uremia, R for respiratory rate, so B for blood pressure, and 65, age more than 65. So before that, let us see a chest X-ray. Now this patient is having fever with dry cough. And if you see the chest X-ray, you don't find any consolidation. You only find some bilateral haziness. So this bilateral haziness is nothing but interstitial pattern. And whenever you find this in combination, your suspicion can be an atypical pneumonia. And usually common cause of atypical pneumonia will be mycoplasma. So fever, dry cough. But the situation has changed for the last 2 years. So if you find any atypical pneumonia right now, you have to always suspect COVID. But most probably after this Omicron, COVID might become endemic like any other pneumonia. We may not see that commonly. So the standard guidelines mention fever, dry cough, interstitial pattern. So we have to suspect it as atypical pneumonia. Now let us see what are all the investigations that should be done in a hospitalized patient of pneumonia. See, once again, the ATS guidelines or the BTS, British Thoracic Society, or Indian College of Chest Physicians. So nobody asks you to do any blood investigations or sputum investigations in a patient whom you are treating at home. So in outpatient treatment for pneumonia, no need any investigations. But for hospitalized patients, so hospitalized patients, so keep this in mind. So if the patient is hospitalized due to pneumonia, so in them only you should perform investigations. So all this. So in hospitalized patients only, generally we perform investigations. So apart from routines, so routines in the sense when you hospitalize a patient, you do some routine blood tests. You do CBC, complete blood count, and you do some RFT, LFT, electrolytes, all these routine investigations as per patient clinical and radiological history for diagnosis of pneumonia. So there are 3 samples that you can send. So one is a blood sample. So what are the investigations done in blood specific for infection? What are the investigations that should be done in sputum specific for pneumonia? And what are the urine tests done specific for pneumonia? So in hospitalized patients, apart from routine blood investigations as per patient clinical and radiological history. So it is not a routine investigations that you don't say that I'll send sputum for all organisms, even the rare organisms. See, depending upon the patient's clinical and radiological history, so you should suspect it to be that pneumonia, and accordingly you should send the investigations. So in the blood, especially in hospitalized patients, you can send blood culture before starting the antibiotics. And along with that, serology for relevant organisms. So you're thinking it as Legionella pneumonia or Mycoplasma pneumonia. So there are some blood tests available for diagnosis of Legionella and Mycoplasma. Then coming to sputum. So we have gram stain and culture for common bacteria. Again for fungus here, especially aspergillus. So we are having serum galactomannan. So you can do galactomannan for diagnosis of aspergillus if you are unable to get sputum, if you are unable to do bronchoscopy, especially in sick patients. Now sputum examination, you have to send it for gram staining and culture for common routine bacteria. So to look if there is any routine bacteria. And whenever you are suspecting it as some opportunistic infection or tuberculosis, you have to do that staining also. So if you suspect it to be tuberculosis, especially in our country, you should send it for acid-fast staining CBNAT. And if you are suspecting it as a fungus may not be appearing on gram stain, you should specifically write to the microbiologist, I am suspecting it as fungus. So do fungal staining and culture of sputum. And if you are suspecting it as PCP, pneumocystis pneumonia. Now this patient is HIV and you got some sputum, you are suspecting it as PCP. So pneumocystis pneumonia you are suspecting, and for PCP there are special stains. So what are these special stains? When I discuss HIV, there I will discuss all the opportunistic infections. So fungal pneumonias, in that fungal pneumonia, we will discuss this pneumocystis pneumonia. So again, if you find any patient with pneumonia, immunocompetent, writing fungal and PCP is not practical. So it depends upon the patient clinical and radiological history. So poorly controlled diabetic with pneumonia, you should definitely rule out fungal. A immunocompromised patient, organ transplant patient or HIV patient with pneumonia, you should definitely rule out pneumocystis pneumonia. And what are the urine tests available for pneumonia? So we have urine antigen test that is routinely done for Legionella. So urine antigen test for Legionella. So when a patient with pneumonia is admitted, so these are the investigations apart from routine investigations. So in the blood you can send it for culture, serology for relevant organisms, sputum gram staining culture for common bacteria. Along with that, if you suspect it as tuberculosis, AFB staining, CBNAT, fungal staining, culture of sputum, fungal culture of sputum, PCP staining, and if you are suspecting it as Legionella, urinary antigen test for Legionella. Now if the above reports are inconclusive, still there is a pneumonia, so you have to go for a better sample. So better sample is always going into the lung and taking ample sample. So what is that ample sample? It is bronchoalveolar lavage. So we can also perform molecular assays for Mycoplasma, Legionella and respiratory viruses. So molecular assays nothing but PCR, polymerase chain reaction, and this PCR has become famous especially due to COVID. And if above reports are inconclusive, so you can go into the lung and take BAL. So in few centers we also take a bronchial brushing, so also called as protected specimen brush. I'll just show you the procedure. So already I have discussed what is this bronchial brushing previously in interventions. Once again I'll show you. So apart from this blood, sputum, urine test, we can also go for swab test, throat swab or nasal swab for PCR, which can identify atypical organisms such as Mycoplasma, Chlamydia, Legionella and respiratory viruses, especially for swine flu and now definitely for COVID-19. And if above reports are unconclusive, still there is a pneumonia and you are suspecting it to be some infection related disease, so you should put a bronchoscope, directly visualize that area, take this sample in the form of bronchoalveolar lavage or in few centers they also practice taking bronchial brushings, also called as protected specimen brush. But usually the preferred is bronchoalveolar lavage. So in majority of the centers we do bronchoalveolar lavage. So these are the investigations that should be done for a community acquired pneumonia patient admitted in the hospital. So if he is sent home, so if it is outpatient treatment, no need any investigations, any blood investigations, blood for culture or sputum investigations or urine investigations. But if you are admitting in hospital, depending upon the clinical scenario, you have to advise these investigations. Now what is this procedure? Tell me. So I have put my bronchoscope. I am injecting some saline. And again, this saline will go to the level of alveoli, hit the alveolar walls and bring the secretions and organisms out. So later I am going to suck these secretions out. So this is the classical bronchoalveolar lavage. So in the next thing, I have shown you the protected specimen brushing. I have inserted the bronchoscope and through that I am sending a brush. So that brush will go into the targeted segment and it is going to take the sample from there. So once again this brush I am bringing it into the sheath, and because it is protected by the sheath, it is also called as protected specimen brushing. So this is the bronchial brushing. But in majority of centers we use bronchoalveolar lavage commonly. So these are the set of investigations that can be sent in an hospitalized patient. Depending upon the patient's clinical and radiological history, blood investigation, sputum investigation and urine investigation. Now coming to the assessment of severity of pneumonia. As I told you, we have a very simplified practical scoring system called as CURB 65. C stands for confusion. U stands for blooduria, more than 7 millimole per liter, or in terms of Indian units, more than 40 mg%. R for respiratory rate, more than 30 per minute. B for either systolic blood pressure less than 90 mmHg or diastolic blood pressure less than 60 mmHg, and 65 is age more than 65. For each of this parameter, if it is present, we give 1 point. Now you can get a valid doubt. This is pneumonia. So why have I included confusion, blooduria, blood pressure? Very simple. Any infection, the end complication is sepsis. In sepsis, there can be multi-organ dysfunction. If brain is involved, there can be confusion. If kidney is involved, renal dysfunction, blooduria can increase. If there is septic shock, blood pressure can decrease. So if patient is having multiple parameters in this scoring system, what does it mean? Patient is having more severe pneumonia. Coming to the scoring system, if score is 0-1, home treatment with antibiotic will be sufficient. So this is a patient with the best prognosis. Mortality is very less. If score is 2, so this patient require hospitalization. Hospitalize and treat the patient. If score is 3 to 5, you have to consider this as severe pneumonia. So you have to consider this as severe pneumonia. and patient may require ICU admission. Patient may require ICU admission. So this is a patient with poor prognosis and also chances of high mortality. But if you identify and treat him early, so the prognosis will be better. So 0, 1, mild pneumonia, home treatment with antibiotic. 2, hospitalize and treat. 3, consider as severe pneumonia and patient might require ICU admission. Now if you are sending a patient home and treating, so this is called as outpatient treatment. If you are admitting him in hospital, it is called as inpatient treatment. Now because majority of outpatient patients, you are not doing any investigations, so you are treating empirically. So what will be the empirical choice of antibiotics? And also inpatient in the hospital also, the dictum in any pneumonia is hit hard and hit fast. So the dictum is hit hard and hit fast. So give the best available antibiotic in the clinical scenario in the as soon as possible. So hit hard and hit fast within 4 hours. So within 4 hours of hospitalization, if you give antibiotics, patient will have good response. Because of that, no investigation you are getting within 4 hours because culture will take at least 24 to 48 hours. So majority of treatment, let it be in outpatient or inpatient, the initial treatment is generally empirical. So you have to give something depending on the patient's clinical scenario. So local infection pattern and also radiological pattern, you have to give something as soon as possible. So hit hard and hit fast is a dictum in pneumonia treatment in hospital. You cannot delay the antibiotic just admitting him in hospital and waiting for culture. You don't know when that culture report will be available if it is generally a government hospital. So that's why let it be outpatient or inpatient, initial treatment is based empirically only. So now what are those empirical regimens available for community acquired pneumonia? So first thing what you should know is where exactly you are treating him. So is it outpatient treatment? Is it outpatient treatment or inpatient treatment? Simple rule of thumb is if you are admitting him in hospital, so preferred will be injectables. So we generally give injectables more than oral forms. At home, we usually give tablets. So whatever treatment I write in outpatient is generally tablet. So whatever I write in inpatient, it is usually injectable. Now if it is a outpatient treatment, next thing what you should inquire is this patient with comorbidities? So comorbidities in the sense patient might be having diabetes, hypertension, chronic kidney disease, liver disease, chronic lung disease, all those. No comorbidities. So if patient is not having any comorbidities, the treatment is very simple. Single antibiotic. Depending upon the availability, either macrolide or beta-lactam or tetracycline. So any one of the following can be given. So macrolide, beta-lactam, tetracycline. Now if the patient is with comorbidities, the first preferred regimen in our country is beta-lactam plus macrolide or monotherapy with fluoroquinolone. Now if it is inpatient treatment, where exactly in the hospital? Is it in the ICU or in the ward? Non-ICU means ward. If it is non-ICU, the preferred regimen will be injectable beta-lactam with macrolide or monotherapy with fluoroquinolone. Now if it is within the ICU, we have first preferred regimen beta-lactam with macrolide or beta-lactam with fluoroquinolone. So FQ is nothing but fluoroquinolone. Now if at all patient is in ICU, there are few special considerations that you should know. Now patient is in ICU and you are suspecting this pneumonia is due to a bad organism called as Pseudomonas. So patient might be having bronchiectasis related lung infection. Common organism is Pseudomonas and it resulted in ICU admission. So you should definitely cover Pseudomonas empirically at least. So here the treatment will be for Pseudomonas. We have to give anti-pseudomonal beta-lactam along with that fluoroquinolone. So what are the examples of anti-pseudomonal beta-lactams that you know? So common, piperacillin tazobactam, cefoperazone sulbactam, meropenem, those. Now by chance, if community acquired MRSA suspected, now this patient was with severe community acquired pneumonia in the ICU. During your rounds you have found out this fellow is a chronic IV drug user. So in such situation, you may need to suspect it is methicillin resistant staph aureus. Now in such situation, the first regimen that we use in our country is beta-lactam with macrolide with vancomycin or linezolid, or there is another regimen, beta-lactam with fluoroquinolone with linezolid with or without clindamycin. Right now this second regimen is considered as most effective regimen against staph within the ICU. Now if you observe, here I am suspecting staph, but still why I am giving beta-lactam macrolide, beta-lactam fluoroquinolone. Point to know here is, here you are treating a patient with community acquired pneumonia empirically, and it is in the ICU, usually severe form. One suspicion is staph. It doesn't mean his lung is not having common typical and atypical organisms. So the point here is, whenever you are treating especially severe pneumonias empirically, you should give a regimen which has broad coverage. Now if you see in this regimen, this beta-lactam macrolide, beta-lactam fluoroquinolone will take care of common, typical and atypical organisms, whereas this vancomycin linezolid will take care of the specific organism. So why we generally combine beta-lactam macrolide together is, Beta-lactam will take care of the common typical organisms. Macrolide will take care of the atypical organisms. And especially in India, if you notice, even though fluoroquinolone is a very good drug, we are not using it as first-line treatment for community-acquired pneumonia empirically in our country. What is the reason? India is a country with high burden of tuberculosis. If you use all these fluoroquinolones empirically for simple pneumonias, later when the population develops tuberculosis, it might be drug resistant. So that's why write down this important statement. In India, empirical use of fluoroquinolones not indicated due to high burden of TB in the community. So very important statement. So in India, empirical use of fluoroquinolones not indicated due to high burden of tuberculosis in the community. So due to high burden of tuberculosis in the community. So for you to understand easily, I have simplified the empirical regimens of community acquired pneumonia. So from the recent Harrison, and also the same thing is given in the recent Infectious Diseases Society of America, IDSA, ATS joint guidelines also. So first thing, when you see a pneumonia, assess the severity and decide where to treat. Is it at home or is it in the hospital? If it is at home, no comorbidities, what to give? With comorbidities, what to give? If it is in the hospital, what to give in the ward, what to give in the ICU. Now if it is in ICU, you should also look for these bad organisms such as Pseudomonas and MRSA. If Pseudomonas is suspected, what to give? If MRSA is suspected, what to give? Now let us see the common beta-lactams given and what are the doses of the drugs. So I am only discussing with respect to Indian scenario students. So these are the common drugs that you can give. So if you are giving amoxicillin, so you can give it 0.5 to 1 gram, 500 mg to 1 gram thrice daily. So if you are giving amoxiclav, so tablet form 625 mg thrice a day and 1.2 gram thrice a day IV can be given. If he is hospitalized, if you are thinking to give amoxiclav, so the ideal dose for a patient weighing more than 60 kgs is generally 1.2 gram IV TID. Then azithromycin, if you are giving for any pneumonia empirically, 500 mg. Then ceftriaxone. So these are all the common drugs that we give. Ceftriaxone 1 gram BD, cefotaxime 1 gram BD or TID. Then cefepime in few centers they give cefepime 1 to 2 grams BD. Then ceftazidime 2 grams TID. Piperacillin tazobactam. So we have to give, this is again a common drug. So we give 4.5 grams IV. So TID or QID. So 3 to 4 times. So it can vary. Then imipinam cilastatin combination 500 mg to 1 gram. So in few centers they give 1 gram BD also. So 1 gram BD. Then meropenem generally 1 gram IV TID. So don't need to write all these doses. So these doses I will upload as a PDF for you. So again in hospital acquired pneumonia and also ventilator associated pneumonia. So there are few doses. So these are standard doses as per Indian guidelines. So this I have taken from Indian guidelines for community acquired pneumonia. So given by National College of Chest Physicians. So we have something called as NCCP. So NCCP guidelines. So NCCP Indian guidelines, National College of Chest Physicians. So already most of you must be using these antibiotics, but what is the relevance? Why we are giving beta-lactam only in few? Why we have to combine beta-lactam plus macrolide? And what to give in the ICU, what to give in the ward for community acquired pneumonia empirically. So this algorithm is very helpful throughout your life. Outpatient, inpatient, no comorbidities with comorbidities. Non-ICU, ICU. And these are the doses of drugs that should be known to you. So once you administer them frequently, you will come to know easily. Now the next question is, now this is a patient with pneumonia. He is at home. For how many days you should give antibiotics? Now he is in hospital. You have started injectables. After how many days you should convert it into orals, and after how many days you should stop the antibiotics in community acquired pneumonia. So again, this is taken from Indian guidelines, NCCP, when to discharge, when to stop giving antibiotics. Now see here, if the patient starts accepting orally and or ephebril and are hemodynamically stable for at least 48 hours. So you can switch the antibiotics. To oral forms. So we can switch the antibiotics to oral forms. So if the patient is ephebril for at least 2 days and he is hemodynamically stable and he is accepting orally, you can switch the IV antibiotics to oral forms. Then what is the duration of treatment? So in outpatient, we generally should give only 5 days. Whereas inpatient, the duration of antibiotics is usually 7 days. Duration of antibiotics is usually 7 days. So again, very important. Sir, for how many days you should give antibiotic for a patient treated on outpatient basis? 5 days. In inpatient, for how many days? Inpatient patient, how many days you should give antibiotics? 7 days. So I see many people writing 10 days, 2 weeks antibiotics. There is no point. So there is no evidence. So evidence only says that for outpatient, it is only 5 days. For inpatient, it is 7 days course of antibiotics is sufficient. 7 days course of antibiotics is sufficient. So if patient is accepting orally and he is ephebril and hemodynamically stable for at least 48 hours, so if you can put him on oral forms and you can discharge. So you can put him on oral forms. As soon as he is accepting orally, so there is no point in keeping him in hospital. So if he is accepting orally and he is not having fever, he is hemodynamically stable for the last 2 days, so you change the antibiotic to oral form and you discharge him. So outpatient treatment, 5 days antibiotics. Inpatient treatment, 7 days antibiotics. So this is regarding the community acquired pneumonia students. So we have discussed the clinical presentation of 5 common organisms happening in the community, typical, atypical. So what are the investigations to be done in blood, sputum and urine? And how will you assess the severity, and what is the empirical regimens, and how to discharge the patient. Now coming to the most complicated topic, that is nosocomial pneumonia. So brief revision, what is this nosocomial pneumonia? It is something happening in the medical facility. So if it is happening with respect to ventilator, it is called as ventilator associated pneumonia. So outside the ventilator, it is called as hospital acquired pneumonia. So previously in 2015, there was a term called as healthcare associated pneumonia. But later the guidelines have found out that there is no point in using that healthcare associated pneumonia. So they have removed that word. Now it is only community acquired nosocomial. And in nosocomial we have hospital acquired ventilator. So the standard definition for HAP is it occurs after 48 hours in hospitalized patients. So no need to write down. So these definitions I have discussed in the last week notes, you can see. Occurs after 48 hours in hospitalized patients. Whereas ventilator associated pneumonia, we have a range. Occurs after 48 to 72 hours of which type of mechanical ventilation? Invasive mechanical ventilation. Occurs after 48 to 72 hours of invasive mechanical ventilation. Then who are the common culprits? For hospital acquired pneumonia, most common will be gram-negative bacilli. And if they ask you a single organism, it has to be MRSA, methicillin resistant Staph aureus. Whereas ventilator associated pneumonia, we have early VAP. So early VAP generally responds to antibiotics. So they are non-MDR pathogens. So MDR means multi-drug resistant. Now the problem in infections is they are becoming multi-drug resistant. So early VAP usually will have good prognosis because it is non-MDR pathogens such as. So when do you call it as early VAP? So if it happens within 5 days of invasive mechanical ventilation. If it happens after 5 days. So this is very problematic because these organisms will be very dangerous organisms and they will be multi-drug resistant. So even if you start the routine antibiotics, it will not respond. So what are the good organisms? Streptococcus pneumonia, and H. influenza. Now what are the dangerous organisms? Pseudomonas. Its best friend staph. And their newfound love, Acinetobacter. See, whenever they say nosocomial pneumonia, generally, most probably, they will be referring it to ventilator-associated pneumonia only. Because if there are 100 studies on pneumonia in the hospitals, 70% was on ventilator-associated pneumonia. Because ventilator-associated pneumonia is something hot and happening. So if you don't treat a patient properly on ventilator-associated pneumonia, so the mortality is high. Because of that, most of the researchers have focused on ventilator-associated pneumonia. So if they just mention nosocomial pneumonia, so most probably they are speaking about ventilator-associated pneumonia ultimately. Because most research on hospital-acquired or nosocomial pneumonia has been completely focused on VAP only. Okay. Now these are the organisms. Hospital-acquired pneumonia, we have gram-negative bacilli, MRSA. Ventilator-associated, we have early VAP, streptococcal pneumonia, Haemophilus influenza. Late VAP, these terrible organisms, Pseudomonas, MRSA, Acinetobacter, and most probably the organisms happening in late VAP, they will be already resistant to many antibiotics. So that's why they are called as MDR pathogens, multi-drug resistant pathogens. Now first we will see the pathogenesis. Why will pneumonia happen in hospital and how will it happen after putting an endotracheal tube? So very important slide. So if you go through any standard textbook, the pathogenesis of hospital-acquired pneumonia and pathogenesis of ventilator-associated pneumonia is very complicated. I have given some pictorial description so that you will understand it very easily. Now for hospital-acquired pneumonia, to happen. So this is hospital-acquired pneumonia pathogenesis. The main culprit will be the organisms within your body only. See, always know that when a pneumonia is happening in your body, so either your immune system should be very weak or the organism should be very strong. Now in hospital-acquired pneumonia, what happens is, normally some organisms will be in your oropharynx. They'll be just staying there. They'll be just watching the fun. Now, sometimes these organisms can get aspirated and go into the lung. Now, sometimes what will happen is, apart from the normal organisms, some dangerous organisms can grow into your oropharynx and they can aspirate into your lungs. So the first mechanism is always the aerodigestive tract colonization. So your upper airway colonization. So especially this oropharynx. So colonization of oropharynx by organisms, and these organisms will not just stay. Because of some reason they will get aspirated. They will get aspirated into the lung. So it can be either the normal flora. So now whatever I am drawing with blue. So these are the normal flora. So these normal flora, because of some reason, they can get aspirated into your lung. So these normal flora can grow excessively and get aspirated into the lung. So what are all the normal flora generally residing in your oropharynx? So this streptococcal pneumonia organisms, H. influenza, moraxella, and few staph which are generally sensitive. So methicillin sensitive staph and also candida. So these organisms can aspirate because these are already residing in the oropharyngeal area. So this phenomena is called as primary endogenous. So these are primary endogenous organisms. Already they are staying in your body. Now because patient has become sick, they grow excessively and due to patient's condition. So when patient is sick, his cough reflex might be reduced. So there might be reduced cough reflex, or due to some CNS defect, impaired consciousness, and patient might be using some sedatives to reduce pain, or a patient might be returning from surgery. So all this can result in aspiration. Now there is not much big problem with this primary endogenous organisms because generally they will be drug sensitive, you can treat it. But in few what happens is, these bad organisms can colonize. Now this red. So these red organisms are bad organisms. So what are these organisms? Gram-negative bacilli. Because of some multiple overlapping mechanisms, so gram-negative bacilli can grow in the oropharynx. And these gram-negative include Klebsiella, Proteus, Enterobacter, Pseudomonas. Along with that, methicillin-resistant staph and Acinetobacter. So staph generally is gram-positive. So the gram-negative predominantly. Along with that, MRSA, Acinetobacter can grow, and these, because of host factors, impaired consciousness, some neurological defect, sedative or opioid use, they can get aspirated. So once they get aspirated into the lung, what will happen? It will develop pneumonia. So apart from this, these patients might be using which will alter the gastric pH. So once the gastric pH has increased, so normally gastric pH should be low so that no bacteria will grow. Now once the gastric pH increases, what will happen? There will be a lot of organisms growing it within the gastrointestinal tract. So these organisms can reach the oropharynx. From there, organisms can get aspirated into the lung. And whenever you put some invasive devices, now suppose I am putting an endotracheal tube like this. Say for example, this is the endotracheal tube. Now once I put an endotracheal tube, directly the organisms from the oral cavity. So when you are putting an endotracheal tube, during that procedure, So organisms from the oral cavity can be pushed. So if this is the endotracheal tube, so when you are inserting an endotracheal tube, it comes from the oral cavity. Organisms from the oral cavity will directly be pushed into the lung. And if you are putting a nasogastric tube, organisms from the nasal cavity can go into oropharynx. From there, it can go into the lung ultimately. And already patient is immunocompromised. Because of immunocompromise and malnutrition, again gram-negative bacilli can easily grow. And ineffective hospital infection control measures. So you are not washing your hands before attending the patient. So all the germs in your hand will go into the patient's body. So this is the first mechanism. So aerodigestive colonization and aspiration of normal flora. So this normal flora such as Streptococcus, H. influenza, Moraxella, Staph candida or gram-negative bacilli can overgrow. So what is the reason for gram-negative bacilli to colonize the aerodigestive tract? First thing, because of excess medications which will alter the gastric pH, there can be organisms growing in your digestive tract, so which can come into the oropharynx. From oropharynx, organisms can get aspirated into your lung. And invasive devices such as endotracheal tube, nasogastric tube can directly bring the organisms into the oropharynx. Because of patient's immunosuppression and malnutrition, easily gram-negative bacilli can grow. And inadequate hospital infection control measures. So there is no proper hand washing technique, and you are allowing all the visitors just like instead of a ICU or instead of a hospital ward, you are just making it like a market. Everybody is coming and going. They will bring all the infection. They will bring gram-negative bacilli, which will go into the patient's body and it will colonize. And because of patient's reduced cough reflex, impaired consciousness or excess sedative use, it can get aspirated into the lung. So this is the first mechanism. So aerodigestive tract colonization and aspiration of all these bad organisms. Coming to the next important mechanism in hospital acquired pneumonia. So contaminated water or medication solution. So you are giving a nebulization to the patient. So you are using, instead of distilled water, tap water. So in that water tank there might be Legionella. Now this patient inhales that Legionella and he is developing Legionella pneumonia in the hospital. So contaminated water, contaminated respiratory therapy equipment, and patient is going to inhale those contaminated aerosols. And this contaminated equipment can have so many organisms. It can have gram-positive organisms, gram-negative organisms. All these contaminated equipment related organisms will enter into the lung. And third is, patient might be having some other infection such as endocarditis, infective endocarditis. Through blood it can disseminate into the lung. So this is rare. So this hematogenous dissemination of infection from some other system into the lung is generally a rare cause of hospital acquired pneumonia. So usual and common cause is this. So this you should be knowing. So the colonization of the respiratory tract with organisms, aerodigestive tract, and later these organisms are getting aspirated. So reason for colonization I have discussed. Either because of patient's immunosuppression, malnutrition, normal flora can grow, or even sometimes gram-negative bacilli can grow and this can enter into the lung. And second mechanism, because of contaminated water or medication solution, respiratory therapy equipment, there can be inhalation of contaminated aerosols. So these are the two mechanisms: aerodigestive tract colonization and aspiration of various organisms, and inhalation of contaminated aerosols. Inhalation of contaminated aerosols from the contaminated water or medication solution. Then coming to ventilator associated pneumonia. See students, ventilator associated pneumonia, three important mechanisms. So the first mechanism is when you are intubating. So when you are intubating, so you yourself, by putting the tube, you are pushing some secretions from the oral cavity into the lung. And second important thing, as long as the tube is in place, along the walls of tube, from the oral cavity, directly organisms can enter into the lung. And third important thing, that ventilator circuit, if it is not changed properly, or that ventilator itself is huge source of infection. From the ventilator, organisms will go into the tube. From the tube, they will go into the lung. And also, on the outer surface and inner surface of the tube, there will be a biofilm formation. So organisms can gradually sediment on the tube. And once you do suction or once you do any active maneuvers, so from the biofilm, gradually few organisms can get spilled into the lungs. So I'll show you the mechanisms again with the help of a few images. So first is during the intubation. Now you are putting a tube. So you are putting a tube. So this tube, suppose there are organisms in the oropharyngeal cavity. So this tube can push these organisms. It will hit the organisms and it can push the organisms into the respiratory tract. So first is aspiration during intubation procedure. So aspiration of, so write down aspiration of organisms in oropharyngeal cavity. Aspiration of organisms in oropharyngeal cavity. Aspiration of organisms from oropharynx. Aspiration of organisms from oropharynx during intubation. Aspiration of organisms from oropharynx during intubation. So the second mechanism is this biofilm formation. So biofilm means a film or a coating containing organisms. So biofilm can form inside and outside. So if this is the endotracheal tube, so gradually there will be a biofilm formation. So the organisms can sediment in the tube inside and also outside. So once you do some suction or these organisms, this film can gradually break by time, and organisms from the tube, they can go into the lung. You can see this is the biofilm. So this everything is the biofilm, and these from the biofilm, time to time organisms can spill into the lung. So biofilm can form inside and outside of the endotracheal tube, and this biofilm can serve as a bacterial reservoir. So this biofilm will be containing so many bacteria, and time to time they can spill into the lungs. So spillover of bacteria from the biofilm into the lungs. So spillover of bacteria from the biofilm into the lungs. And third important thing is the contaminated secretions and respiratory equipment. So secretions can pool above the endotracheal cuff and intermittently seep around folds in the cuff, particularly if the cuff is underinflated. Now you know that this is the endotracheal tube. So you should apply adequate cuff pressure. So if you give excess cuff pressure, what will happen? There will be trauma to trachea. You should adequately inflate the cuff. So once you inflate the cuff, what will happen is properly whatever secretions are reaching from the oral cavity, so they will just stay here. So they will not seep into the lungs. Now instead of doing that, if you underinflate the cuff, now suppose let this be the trachea, and you have inflated the cuff properly so that the tube is in place and secretions are not going down. Now if this is the tube and let this be the tracheal wall, now you have not inflated the cuff properly. So you have not inflated the cuff properly. So because of that, what will happen? The secretions from the subglottic area, these secretions, previously they are standing here. Now these secretions can seep into the respiratory tract easily. So the contaminated secretions and respiratory equipment. So and contaminated respiratory equipment. And if you are doing a suction with a contaminated catheter, so all the organisms can directly go into the trachea. So these secretions can pool above the endotracheal cuff and intermittently seep around the folds in the cuff, particularly if the cuff is underinflated. So three mechanisms. So mechanism is during intubation procedure, aspiration of microorganisms from the oropharynx. Second mechanism, a biofilm formation. So within the tube and outside the tube, and this film can serve as a bacterial reservoir, and from this gradually bacteria will spill into the lungs. And third, contaminated secretions. If you don't give proper cuff pressure, contaminated secretions can intermittently seep around folds in the cuff, and particularly if the cuff is underinflated, and also use of contaminated respiratory equipment. So usual culprit is that suction catheter. So using the same suction catheter, not changing the suction catheter properly. So because of that, there will be contamination of respiratory tract with this contaminated respiratory effect. So three mechanisms for ventilator associated pneumonia: aspiration of microorganisms from oropharynx during intubation procedure, biofilm formation, contaminated secretions, and contaminated respiratory equipment because of contaminated respiratory equipment and contaminated secretions. Now let us see the standard protocol for identifying hospital acquired pneumonia or ventilator associated pneumonia. Now the guidelines are similar. When to suspect patient is having a nosocomial pneumonia. So there is a standard guideline given by the CDC. So Modified Center for Disease Control and Prevention. So CDC has given, and this is a criteria used both for hospital acquired and ventilator associated pneumonia. So patient should be having chest radiograph opacities. So you have taken a chest radiograph. So this should be new, or already patient is having old infiltrate that has progressed, or persistent infiltrate or cavitation. Along with that, at least two of the following. So radiological evidence, along with that, at least two of the following. Patient has developed fever. Patient is having either leukopenia, WBC count less than 4000, or leukocytosis. Both are not good. More leukocytes is not good, less leukocytes is also not good. All this suggests there is a sepsis. And patient is having altered mental status. So new altered mental status and no other recognized cause in elderly. And new onset of purulent sputum or increased respiratory secretions. Up to now patient was comfortable. Now the color of sputum, from white it has become yellow, now it is a yellowish brown. And also the amount of respiratory secretions has increased. And patient is having worsening gas exchange. Previously patient saturation was 94-96 on room air. Now patient saturation on room air is 90%, or patient oxygen requirement has increased. Previously patient was comfortable on 2 liters oxygen. Now he is requiring 5 liters of oxygen. So that is worsening gas exchange. And new onset or worsening cough, dyspnea or tachypnea. So patient was comfortable up to now. Now patient is having worsening cough. He is having shortness of breath or increased respiratory rate. And you have put here stet. There are crepitations or bronchial breath sounds, which indicates again consolidation. So to call it as hospital acquired or ventilator associated pneumonia according to this criteria, CDC criteria. So there is also another criteria, but commonly used is this CDC criteria. So at least two of the following along with chest radiographic opacities, new, progressive or persistent infiltrate or cavitation with two of the following. Patient is having fever, leukopenia or leukocytosis, altered mental status with no recognized cause in elderly. See, again, altered mental status can be a feature of sepsis. New onset purulent sputum or increasing respiratory secretions. Worsening gas exchange. New onset worsening cough, dyspnea or tachypnea. Rales or bronchial breath sounds. And once again, for diagnosis of hospital acquired or ventilator associated pneumonia, so most important is chest X-ray along with that clinical evidence. So this is more of a clinical criteria because we are not using any culture gram staining here. Fever, leukopenia, altered mental status with no recognized cause in elderly, new onset of purulent sputum or increased respiratory secretions, worsening gaseous exchange, new onset worsening cough, dyspnea, tachypnea, rales, bronchial or bronchial breath sounds. Apart from this, especially for ventilator associated pneumonia, there is something called as CPIS, Clinical Pulmonary Infection Score. So majority of ICUs for assessing ventilator associated pneumonia, they use this scoring system. So this is called as CPIS, Clinical Pulmonary Infection Score, and it is specifically used for ventilator associated pneumonia. So the previous system, it is both for hospital acquired and ventilator associated pneumonia. So you can use it to diagnose nosocomial pneumonia generally. Let it be hospital acquired or ventilator associated. But this CPIS, Clinical Pulmonary Infection Score, is used for ventilator associated pneumonia. So again, CPIS is more of a complicated scoring system. So you have to keep this chart with you and you have to assess the patient. So what are the parameters that we take into consideration? So we take the parameter and we give the score 0, 1, 2. So if the parameter is very worse, it is 2. If the parameter is not just worse, if it is not that worse, it is 0. So depending upon the severity. So if it is a very bad situation, we give score 2. If it is not that bad, we give 0. In between is 1. So first parameter is tracheal secretions. So if at all tracheal secretions are not there, you have ventilated, you are aspirating, you are doing suction, there are no tracheal secretions. So the score is 0. If there are abundant tracheal secretions but they are clear, we give 1 point. They are abundant but purulent, we give 2 points. See here, no secretions is not bad, so 0. Abundant and purulent secretions is bad, we generally give score 2. So the first parameter that we take in clinical pulmonary infection score is the tracheal secretions consistency and the quantity. So if it is abundant and purulent, it indicates a bad phenomena. Then chest X-ray infiltrates. The next parameter. So no infiltrates at all. You have taken a chest X-ray after connecting to a ventilator. There are no infiltrates. No need to worry. So there are some diffuse infiltrates. So bilateral diffuse infiltrates. So 1 point. Localized and more of a consolidatory pattern, it is 2. Now diffuse infiltrates, it can be even due to patient might be having ARDS. See here. So why this diffuse infiltrates is taken as less problematic here is already patient is having ARDS. So that is a diffuse infiltrates. So it may not be a new onset ventilator associated pneumonia. Now patient with localized pneumonia, it indicates it is a new onset ventilator associated pneumonia. So diffuse infiltrates already patient might be having. So it is because of the pre-existing disease. It is not due to new ventilator associated pneumonia, whereas localized always indicates a new infection. So here in this ventilator associated pneumonia, you have to identify the new infection and you have to give antibiotic against it. So localized is generally taken as more problematic. So more problematic. So then temperature, fever. If the temperature is within normal limits, nothing to worry. 38.5 to 38.9. So the temperature has increased. Fever is there, 1 point. Now hypothermia or hyperthermia, more than 39 or less than 36. Patient has developed hypothermia. It is a bad phenomena. It is a bad phenomena. Then coming to leukocytes. If the leukocyte count is normal, 4,000 to 11,000, no need to worry. Now, if there is predominant leukocytosis or leukopenia, so less than 4,000, more than 11,000, so it is problematic. Then what is 2? So less than 4,000 or more than 11,000 with immature forms. So whenever there are immature forms, it always indicates there is some problem. So whenever there are some immature forms, it always indicates there is a severe problem in your body. Then PaO2 by FiO2 ratio. So it is an indirect measure of the oxygenation. So if the ratio is good, so it is more than 240, it means no significant hypoxemia, or patient is having ARDS. The score is 0. So it means that this patient is only having ARDS, no possibility of ventilator associated pneumonia. Now this patient's PaO2 by FiO2 is very less, but there is no ARDS. Say for example, patient is having a localized infiltrate. So patient is having right-sided infiltrate after putting on ventilator. Now his saturation has dropped. So his PaO2 by FiO2 ratio has reduced and no evidence of ARDS. So ARDS generally doesn't happen after putting on ventilator. After ARDS, patient is generally put on ventilator. So this is the usual occurrence. So and there is no ARDS, no evidence of ARDS. It means chances of ventilator associated pneumonia is very high. Then microbiology. So you have collected the secretions. So the tracheal aspirate or bronchoalveolar lavage. So it is negative. So chances of ventilator associated pneumonia is less. It is positive. Chances of ventilator associated pneumonia is high. So these are the parameters that you should take into consideration. So the tracheal secretion, see at least in exam, you should know the names of these 6 parameters. No need to know that scoring, what is 0, what is 1, what is 2. That is difficult to remember. At least represent this. So what are the parameters taken in clinical pulmonary infection score? We take tracheal secretions, chest X-ray infiltrates, temperature of the patient, the leukocyte count, the PaO2 by FiO2, so the oxygenation of the patient, then microbiological evidence. Is there any positive culture? Is there any microbiological evidence that is positive culture? Positive culture. Now when you suspect that there is ventilator associated pneumonia, if the score is more than 6, a score more than 6 at baseline is suggestive of new pneumonia. So that is ventilator associated pneumonia. So you have to assess the patient with this scoring system. So you have to take into consideration the consistency and quality of tracheal secretions. Are they rare, abundant and purulent? Chest X-ray infiltrates, no infiltrates, diffuse or localized. Temperature 36 to 38.4, 38.5 to 38.9, more than or equal to 39 or less than or equal to 36. The leukocytes. So if it is more than 400, less than 11,000, not to worry much. Less than 4,000 or 11,000, it's a worry. So which is very bad situation, less than 4,000 or more than 11,000 plus banned forms, immature forms. Immature form always implies something bad is happening in the body. So oxygenation ratio, if it is maintained more than or equal to 240. If it is less than or equal to 240, then it is problematic. So microbiology, is it negative for organisms? Good. If it is positive, again it is suggestive of ventilator-associated pneumonia. So you have to assess with this score, and any score more than 6 is suggestive of pneumonia. But for routine practical purposes, so let it be that CDC or clinical pulmonary infection score. So usually to suspect it as a ventilator or hospital-acquired pneumonia, we generally take patient's X-ray and patient's clinical status. So is the patient having fever, any worsening gaseous exchange, any leukocytosis, or any purulence of secretions. So we usually go by clinical and radiological criteria. I'll just give an example. So the clinical features of hospital acquired or ventilator associated pneumonia. So patient generally can have fever, leukocytosis, increase in respiratory secretions, and on auscultation, clinical examination, findings on consolidation. Chest X-ray, there can be a new infiltrate or progressing radiographic infiltrate. And signs of worsening can be seen. Patient can have tachypnea, tachycardia, hypoxemia. So you have to take into consideration the clinical and radiological. So this was a patient. So on arrival to the hospital, so this was the initial X-ray. So after 3 days, when they repeated the X-ray, you could see some pneumonia developed. So this is a typical example of hospital-acquired pneumonia. So to call it as a hospital-acquired or ventilator-associated pneumonia, even if you don't know this CPIS or CDC criteria, just common sense. So patient has developed a new onset fever, leukocytosis, respiratory secretions have increased or the purulence have increased, and you put your steth. There is a findings of consolidation. There is bronchial breathing or crepitations. And chest X-ray you have taken. When compared to the initial chest X-ray, now in the chest X-ray, you are able to see infiltrates. So new infiltrates or progressive infiltrates. And patient, when compared to the previous 2 or 3 days, there is increase in shortness of breath, tachycardia, hypoxemia. So this is how we generally diagnose. So we are not using this CPIS score routinely because it is a problematic score, not that practical. We go by our clinical common sense. So patient is having fever, leukocytosis, and new infiltrate, and patient is worsening, either tachypnea, tachycardia, or hypoxemia. In such situation, we can consider it as a nosocomial pneumonia. If the patient is on ventilator, it is called as ventilator-associated pneumonia. Not on ventilator, it is just called as hospital-acquired pneumonia. Now suppose there is a situation like this. Now the same patient you say, now this is the patient. Now what are all the investigations that are to be done? So if patient is able to expectorate, if he is a non-ventilated patient, we should go for sputum examination. Sputum examination, gram staining, culture sensitivity. If it is a ventilated patient, we should go for invasive sampling. So either bronchoalveolar lavage or the bronchial brush. So tracheal aspirate may not be that sensitive because it might be contaminated with oropharyngeal contents. Then CRP. So CRP will give you a rough idea regarding the progress of the infection. So serial CRPs and serial procalcitonin can help you to reduce the antibiotics, and also blood culture to identify the organism. So these are the simple investigations. No need any fancy investigations in nosocomial pneumonia. Sputum examination, if sputum is available, send it for culture. And if sputum is unavailable, invasive sampling, either bronchoalveolar lavage or protected specimen brush, bronchial brushing. So CRP procalcitonin can help you to see the progress or the regress of the disease, and it can help you to decrease the antibiotics, and blood culture. So generally what we do is we initially empirically start the treatment. Based on our clinical suspicion, we suspect some organism and we start. And once the culture reports arrive, we narrow down the spectrum. So initially we give a broad spectrum antibiotics, and once we have isolated a specific organism, so we can give antibiotics targeting that organism only. Now before starting antibiotic, we have divided the organisms into non-MDR, MDR. So when do you say this pathogen can be MDR, multi-drug resistant? So the biggest problem in nosocomial pneumonia is nowadays we are having infections due to MDR pathogens. So if you give antibiotics, also routine antibiotics, it will not work. You have to give higher antibiotics. You have to give higher antibiotics. See, what are the indications of sending procalcitonin? So you have suspected it as hospital-acquired pneumonia or ventilator-associated pneumonia. So if there is an infection, you can send procalcitonin. So especially bacterial infection. So this procalcitonin is nothing but a substance produced in your lung cells in response to bacterial toxins. I'll write it for you. So procalcitonin is a substance produced by the cells in your lung in response to bacterial toxins. So when you feel it is a bacterial infection, you can do procalcitonin. And serial procalcitonin, initially procalcitonin was high. Now the procalcitonin has decreased. So serial procalcitonin can tell you that antibiotics are working, so the toxicity has reduced. So this procalcitonin is produced in response to bacterial toxins. And serial procalcitonins can help you to reduce the antibiotic, de-escalate the antibiotics. So you have initially started higher antibiotics, now procalcitonin has come down. So you can reduce the antibiotics. So you have started dual antibiotics. Now you can decrease it to single antibiotic. So what is the indication for sending procalcitonin? Bacterial infection, especially severe bacterial infection. So you can send it in bacterial pneumonia. What is procalcitonin? It is a substance produced in your body in response to bacterial toxins. So if procalcitonin is high, more suggestive of bacterial infection. Then what are the risk factors for MDR pathogens? So if you see Harrison or CMDT, so there is a very complicated list. But for all practical purposes, for you to represent in the exam and for clinical practice, I usually make these risk factors for MDR pathogens with help of alphabets. A, B, C, D. What are A, B, C, D? So patient has taken IV antibiotics in last 90 days. So patient previously in the last 3 months, he was treated for some disease with IV antibiotics. So once IV antibiotics have sent into his body recently, it means your body's organisms must have got resistance against this organism. Second, he has been hospitalized for more than 5 days, prior HAP or VAP. So the longer the hospital duration, the higher the chances of bad organisms. So if the patient is staying in hospital for long, it means his illness is more severe. It means his defense mechanisms are less competent. It means the chances of bad organisms to proliferate more will be high. So A for antibiotics in last 90 days, B for being hospitalized for more than 5 days prior to HAP or VAP. C, patient is having critical illness. He is very sick. So very sick means in his body the defense mechanisms are less. So it will be easy for bad organisms and strong organisms to proliferate. So especially patient is having sepsis and also ARDS prior VAP. So ARDS was responsible for ventilator associated pneumonia. So again it means patient is critically ill. Once the patient is critically ill, his body's defense mechanisms are completely knocked down. So usually in such patients, bad organisms or stronger organisms proliferate and will be responsible for pneumonia. And patient had dialysis. So prior VAP. So in the last 1 or 2 months, patient is had a dialysis. Again, dialysis, patient can have multi-drug resistant pathogens in his body. So if you find this in any patient, so there is a patient with VAP or HAP. Okay, there is a patient with VAP or HAP. So within the history, you have found out patient has taken IV antibiotics for some other disease in the last 1 month. So it means in his body, chances of MDR pathogens are high. Or patient is in the hospital. He has been referred to you for ventilator associated pneumonia on the 10th day. So it means patient is being hospitalized for many days, means patient's defense mechanisms are not proper. So the organisms responsible for the disease might be stronger and bad MDR pathogens. Patient is critically ill. Sepsis is in sepsis or ARDS prior VAP. And again it shows that patient's defense mechanisms are completely knocked down. So this patient requires higher antibiotics against MDR pathogens. And dialysis prior VAP is also a risk factor for development of multi-drug resistant pathogens. So apart from this, if the local antibiogram is available, so few ICUs will maintain their antibiogram. So they will tell you that, sir, in last 1 year in our ICU, MRSA was isolated. More than 20% patients coming with ICU pneumonia or MRSA. Or that ICU might be famous for more than 20% were Pseudomonas. So if it is available, so again you should suspect a more of MDR pathogen. But general risk factors for MDR pathogen A, B, C, D. Antibiotics, especially IV antibiotics, in last 3 months, and he has been hospitalized for more than 5 days, presence of critical illness and dialysis prior to VAP, all this indicates patient is having MDR pathogens. Now coming to the initial treatment before the culture reports can arrive. So initial treatment depends whether it is a low MDR pathogen risk. So if at all patient is having HAP or VAP, and the MDR pathogen risk is low, you can just give a simple beta-lactam or fluoroquinolone. In this situation, a beta-lactam or fluoroquinolone will be sufficient. So the treatment that I am discussing is common for both HAP and VAP. So it is the general treatment for nosocomial pneumonia. It is common for both HAP and VAP. Now you have found out this patient is at high risk of MDR pathogen. So patient had previously given antibiotic, or this is the 6th or 7th day of illness. He is with the nosocomial pneumonia. So it means the pathogen is very strong. So this is a high MDR pathogen risk. So in this you should find out, is this patient in septic shock? He is not in septic shock. So when he is in septic shock, you should make sure you are giving more antibiotics. If he is not in septic shock, what is the antibiotic? You can give a single gram-negative agent. So and usually it will be a higher beta-lactam. Along with this, if the patient is having risk factors for MRSA, so you can add MRSA therapy. So usual risk factors for MRSA, apart from that IV antibiotics, dialysis, is the ICU. So the ICU last 1 year they have isolated MRSA. If at all the antibiogram is available, if that ICU is notorious for MRSA, you should also add MRSA therapy. So this is optional, but generally it will not be minus. So if it is a high MDR risk, it will be usually plus only. So even though in guidelines they say that you follow the local antibiogram to go for MRSA, it is not available in majority of ICUs. If the patient is having high MDR pathogen risk, we give and gram-negative agent. Along with that, we also do MRSA coverage. Now, if the patient is in septic shock, so you need to give 2 gram pseudomonal coverage. So 2 anti-pseudomonal drugs should be given. Along with that, MRSA therapy should be given. So here we give 2 antibiotics. See the difference. Here 1 antibiotic. Here 2 antibiotics. Here we give 3 antibiotics. So depending on the severity of the disease. So generally low MDR risk, 1 antibiotic is sufficient. High MDR risk, no septic shock, 2 antibiotics. High MDR risk with septic shock, we should give 3 antibiotics. Now let us see what are the antibiotic regimens that we are giving. So again, just like low MDR pathogen risk, similar to community acquired pneumonia, we can give amoxiclav or cefotaxime, ceftriaxone, levofloxacin, moxifloxacin. So any one can be given. I think almost all these antibiotics you must be knowing, students. Amoxiclav, cefotaxime, ceftriaxone, levofloxacin, moxifloxacin. Then if it is high MDR pathogen risk, so this single gram negative agent usually should be anti-pseudomonal beta-lactam. Or any drug having pseudomonas coverage. So what are the drugs? So we can give either piperacillin tazobactam, cefoperazone sulbactam, imipenem cilastatin, meropenem, levofloxacin. So along with that, for MRSA, you have to give linezolid or vancomycin. So vancomycin dose is 1 gram BD. So linezolid 600 mg BD. So all these are routine doses. So no need to write down. So the community acquired pneumonia doses and these doses. So these 2 slides I will upload as a PDF. Don't worry. And now see here, if the patient is with septic shock, dual anti-pseudomonal coverage. So this is the regimen that I generally give. So anti-pseudomonal beta-lactam. So here we give anti-pseudomonal beta-lactam. Along with that, a fluoroquinolone such as levofloxacin or moxifloxacin, which has pseudomonal coverage, or aminoglycoside. Nowadays, because of renal toxicity, we generally avoid aminoglycoside, but a few old practitioners give aminoglycoside. So here I told you 3 antibiotics. So number 1 antibiotic is anti-pseudomonal beta-lactam. So number 2 is fluoroquinolone or aminoglycoside. So along with that, for MRSA, we can give linezolid. So number 3 antibiotic. So the frequently used aminoglycoside is amikacin. So amikacin 15 to 20 mg per kg. So if you take normal weight as some 50 to 60 kg, so generally amikacin vial will come as 500 mg. We give 500 mg BD. So this is the dosage. So if there is no septic shock, a single anti-pseudomonal antibiotic will be sufficient. So usually preferred here is piperacillin tazobactam. So we give piperacillin tazobactam here. Whereas dual anti-pseudomonal coverage, so we give piperacillin with levofloxacin with linezolid. So point to remember, in the treatment of hospital acquired or ventilator associated pneumonia, so first you need to divide whether it is low MDR risk. Low MDR risk means the previous risk factors A, B, C, D are not present. High MDR risk, any one of the following. Antibiotic in previous 90 days, or been in the hospital for more than 5 days, or patient is with critical illness, patient has undergone recent dialysis prior VAP or HAP. So this high pathogen risk, again, is it with septic shock or no septic shock? If it is no septic shock, we can give MRSA coverage with a single anti-pseudomonal antibiotic. Whereas if it is septic shock, 2 antibiotics against pseudomonas should be given. anti-pseudomonal beta-lactam with fluoroquinolone, along with that linezolid. If by chance, if that ICU is notorious for Acinetobacter. So nowadays we are seeing Acinetobacter pneumonia. So Acinetobacter generally will not respond to carbapenems. We have to give colistin. So for Acinetobacter right now the drug of choice is colistin. So colistin dose, this is the standard dose. We have to give 9 million units stat followed by 4.5 million units BD. So 9 million units stat followed by 4.5 million units BD. Because in India we are only getting 2 million units vials. So what they do is, so they give 2 million units into 4, 8 million units stat and 2 million units TID they give. So that dose is also practiced in many ICUs. But the standard dose is 9 million units stat followed by 4.5 million units BD. So but in India we practice 8 million units stat, because in India we are getting 2 million units vial and it will be very difficult to split that 2 million units because it is very costly. So we give 4 vials initially, 8 million units stat followed by 2 million units TID. So 2 million units TID. So approximately it will be equal to that dose. So this is regarding the treatment of hospital acquired and ventilator associated pneumonia. So then coming to a very brief topic. So students will ask me, sir, what is meant by non-resolving pneumonia? So before that, prevention of ventilator associated pneumonia. So what are the methods to prevent ventilator associated pneumonia? So first is just write down. So then I'll discuss. Most important, it means we are having high level of evidence. Many studies have shown that the evidence for these methods is very high. Elevation of head of bed 30 degrees to 45 degrees. Oral decontamination with chlorhexidine. Sedation, vacation. Use of NIV wherever feasible instead of IMV. Now these are the 4 methods with high level of evidence known to reduce ventilator associated pneumonia. Now what is elevation of head of bed 30 to 45 degrees? Now see here students, if the patient is completely supine like this, it will be easy for the organisms to descend down from the oral cavity along the sides of the tube into the lung. Now if I elevate the head of the bed, it will be difficult for the organisms to descend into the lungs. So this elevation of head of the bed 30 to 45 degrees is to avoid this easy descent of organisms from the oral cavity into the lungs. Now what is this oral decontamination with chlorhexidine? Daily morning and evening I am going to clean his mouth with chlorhexidine. That will decrease bad organisms in the oral cavity, because ultimately the oropharyngeal colonization is responsible. So organisms from the oral cavity, so they can seep into the lungs. So once you decrease the pathogens, it will reduce. Then sedation, vacation. Now this is a fancy term. Vacation means giving break to sedation. Now once you reduce sedation, patient cough reflex will improve. So patient can at least cough out the secretions into the trachea, and you can put a suction and remove those secretions. So persistence of bad secretions in the lung, what will it do? It will result in infection development. So if secretions are just staying there, so those secretions can get infected and it will result in ventilator associated pneumonia later on. So sedation, vacation. So if you reduce the sedation, patient's cough reflex will come back. He can at least clear the secretions. He can cough out into the trachea. you can put a suction and remove all those bad secretions. And whenever there is possibility, use NIV instead of IMV, because NIV you are not putting a tube, you are just giving it through a mask. So the chances of ventilator associated pneumonia is very less. So elevation of head of bed 30 to 45 degrees, oral decontamination with chlorhexidine, sedation, vacation, use of NIV wherever feasible instead of IMV. So these four are most important. Now, apart from this, there are few other strategies which are having intermediate level of evidence. So they are not having high level of evidence, intermediate level of evidence. So these are now 4. Now let us see number 5. So number 5 is continuous removal of subglottic secretions. So we have discussed earlier. So along from the oral cavity, some secretions can pool at the glottic region, and these secretions can get infected and it can gradually seep into the lower respiratory tract. Now we are having specialized endotracheal tubes with continuous suction channel through a dorsal lumen. So there will be a dorsal lumen and there will be, you can suck out the secretions even from the glottis, outside the tube also, around the tube also. So to prevent above the cuff, to prevent drainage accumulation. See here, if this is the tube, normally when you put a suction, you can only suck out the secretions from the tube. Now this specialized tube will have a port like this. So from this also you can suck out the secretions. So these are specialized tube which can facilitate removal of that subglottic secretions. So apart from the normal cuff, see this is the port. This is the port to inflate the tube. So there is also another port. So through this port, one can easily suck the secretions from the around the tracheal tube also. So this is continuous removal of subglottic secretions with the specialized tube. So again, the evidence level is not that high, intermediate level. So number 6. We should avoid nasal insertion of endotracheal tube and also gastric tubes. So if you put it from the nose, bad organisms can go into the lung. And important thing is you should at least maintain 20 centimeter H2 of pressure in the endotracheal cuff. I told you, if the cuff is not inflated properly, organisms can go down. So what you should do, you should properly inflate the cuff. Okay. So duration of antibiotics, just I'll tell you after this how to prevent ventilator associated pneumonia. After this I'll tell you duration, don't worry. So proper inflation of the cuff to 20 centimeter. So it will prevent leakage. Again, if you increase the cuff pressure, it can cause damage to surrounding tracheal wall into the lower respiratory tract. Then this is very important. You should avoid unnecessary proton pump inhibitors, Pantop, Ranitidine. So what it can do is, so this can increase the gastric pH. So once the gastric pH increases, so now if the gastric pH is less, bacteria will not overgrow. If gastric pH increases, there will be increased bacterial burden. So this is also intermediate level of evidence. So if you give unnecessarily Pantop histamine, so even though stress ulcer prophylaxis is required, so again it is risk benefit ratio. If you feel this patient will bleed, so you can, his ulcers will cause bleed, you can give Pantop. So again, that's why this is not mandatory. So you have to avoid PPEs and histamine blockers because it can increase the gastric pH and it can increase the gastric bacterial burden and it can increase the risk of VAP. So if you give all these drugs, the pH will increase, bacteria will grow, and this from the gastric tract, if patient is having some belching or aspirations, it can come into the oropharynx. From the oropharynx, it can go into the lung. So which is better give in this patient, sucralfate might be given, because sucralfate may not cause that huge changes in the gastric pH. Then next important thing is another thing known to decrease ventilator associated pneumonia, selective decontamination of digestive tract. Now after giving this PPIs, all this, sometimes infection bacteria can outgrow in the digestive tract. So to avoid that, you do selective decontamination with fluoroquinolones or with some cotrimoxazole to eradicate potentially pathogenic bacteria. So these are the 8 methods, but most important will be those 4 methods because they are having high level of evidence. Apart from this, we have continuous removal of subglottic secretions. So avoiding nasal intubation and maintaining cuff pressure 20 centimeter H2O, and avoid unnecessary PPIs because these can increase the gastric pH and increase the growth of pathogenic bacteria, and selective decontamination of digestive tract. So these are the 8 interventions. So in the exam, if they ask you prevention of VAC, you should explain all these 8 interventions. Now next, coming to duration of treatment. So you have done all this, but still ventilator associated pneumonia has occurred. Duration of treatment in ventilator associated pneumonia. So in the previous guidelines, it was mentioned that the treatment should be for 14 to 21 days. But the new guidelines, they have found out there was no much difference if you are giving antibiotics to 7 to 10 days versus 14 to 21 days. So if they ask you what is the ideal duration, it is 7 to 10 days. And all this should be followed according to patient's clinical response. So if patient is clinically responding, 7 to 10 days treatment is more than enough according to new guidelines. So old guidelines 14 to 21. In 2019, we have this IDSA guidelines. So it has clearly mentioned, many studies have shown that there is no difference between treatment of 14 to 21 days or 7 to 10 days. So there was no much difference. So new guidelines mention that if the patient is clinically improving, the guideline should be, the treatment duration should be 7 to 10 days. So now it is 7 to 10 days. For community acquired pneumonia in hospital, 7 days. In outpatient, it is 5 days. For ventilator associated pneumonia and also, so both will be together. Ventilator associated pneumonia and hospital acquired pneumonia, the guidelines will be together. They go hand in hand. So according to new guidelines, it is only 7 to 10 days. Then coming to non-resolving pneumonia. So when to call it as non-resolving pneumonia? Now you have given antibiotic therapy. So despite antibiotic therapy, there is no radiological clearance. So complete clearance should happen 1 month. So usually 1 month to 3 months is taken for few infections. So it depends upon the infection. So routine infections such as streptococcus, 1 month will be sufficient. So I am just taking into consideration streptococcus here. Or within 2 weeks, 50% clearance has not happened. Or patient is not having clinical response. So generally, when compared to chest X-ray, there will be first clinical improvement. So despite adequate antibiotic therapy, patient is not responding in 2 weeks. Or patient chest X-ray is not showing 50% clearance by 2 weeks. Or patient's chest X-ray is not showing clearance within 1 month. So this non-resolving pneumonia is a vague term. if any one of the following is present, you can call it as non-resolving pneumonia. Clinically not improving by 2 weeks. Radiologically 50% clearance has not achieved by 2 weeks, or radiologically complete clearance has not achieved by 1 to 3 months, because for few infections it will take more time. So this streptococcal infection might resolve in 1 month, but few infections can take more time. So because we usually see streptococcus as a common organism, so I have used the term 1 month. So clinical resolution within 2 weeks, or complete radiological resolution within 1 to 3 months. If it is not happening, it is called as non-resolving pneumonia. Now what are the causes of non-resolving pneumonia? So the causes can be divided into infectious causes. So you might be thinking it as streptococcus, but there might be tuberculosis, there might be fungus, there might be some other opportunistic infections. So wrong organism. Second thing is wrong antibiotic. So this organism may not be responding to the antibiotic that you have given. Or third, it can be due to complication of the disease. You thought it as simple pneumonia, but patient has developed empyema. Patient has developed bronchiectasis. So the treatment for empyema and bronchiectasis will be different. So you can divide it into infectious and non-infectious causes. So it might be malignancy, it might be connective tissue disorder. So let us see the etiological causes of non-resolving pneumonia. So I have made a simple table for you to understand. So infectious causes, non-infectious causes. So whether is it any infectious cause or non-infectious cause. Again, infectious causes, it can be host related, it can be organism related, it can be host related. Host related in the sense why it is not resolving. Because host might be immunocompromised. His immunity might take more time for that infection to be resolving. Patient might be smoking. Again, if he is smoking, so it will take a lot of time for the infection in the lung to resolve. Patient might be having comorbidities, diabetes. So it will again take a lot of time for that infection to resolve. Some defects in the defense mechanism, malnutrition. So infectious causes in that host related aspects. Then organism related, presence of a resistant organism. So you might be having Pseudomonas which is resistant to conventional treatment, and presence of unusual organisms. This patient might be having tuberculosis, non-tubercular mycobacteria, rare organisms such as nocardia, pneumocystis pneumonia, fungus such as aspergillus, cryptococcus, histoplasmosis, or coccidiomycosis. So patients' lungs might be harboring these infections. Or animal related infections such as Coxiella burnetii, exposure to cats, exposure to birds, Chlamydia psittaci. So patient might be having organisms, unusual organisms such as TB, non-tuberculosis mycobacteria. So if these do not respond with conventional beta-lactams, nocardia, pneumocystis, fungus, and other organisms, rare animal related, Chlamydia psittaci or Coxiella burnetii. And third is disease related. So there was an infection, you started giving antibiotic, but unfortunately there was complication of the disease. There might be development of empyema, lung abscess. So for empyema you have to put an ICD and drain. For lung abscess the treatment is completely different. Or metastatic infection. So you thought it was bacterial pneumonia all the time, but patient was having infective endocarditis, and that has migrated into the lung, and that was the reason for this non-resolving pneumonia. So if you only treat that infective endocarditis properly, so this metastasis will not happen. So infectious causes of non-resolving pneumonia, it might be host related, organism related, or disease related. So disease related in the sense disease might have got complicated, or it might be a complication from elsewhere. Example, infective endocarditis. Then coming to non-infectious. So non-infectious cause of non-resolving pneumonia, you should rule out the possibility of any malignancy. So few malignancies can present with collapse, and later that area can get infected, resulting in consolidation and fever, cough, all those. Any chances of inflammatory disorders, connective tissue disorders, hypersensitivity pneumonitis, eosinophilic pneumonia. We have discussed acute eosinophilic pneumonia can present with acute shortness of breath, bilateral chest X-ray infiltrate. It can present similar to ARTS. Any organizing pneumonia, cryptogenic organizing pneumonia I have discussed in ILD. So all the presentation will be similar to pneumonia, but it is not due to microorganisms. It is due to some unknown mechanism. There will be accumulation of granulation tissue within the airways. So here it is due to inflammation. So the treatment is not antibiotic organizing pneumonia. The treatment is steroid. So any alveolar hemorrhage syndromes. So patient might be having Goodpasture syndrome, Wegener's granulomatosis. Because of blood filling into the lung, sometimes it might appear as consolidations. Then drug related. Patient might be taking nitrofurantoin, amiodarone, bleomycin. All this can cause infiltrates in the chest X-ray. And because of this drug related damage, patient can have some fever, cough. So the presentation might be similar to pneumonia. So once you identify it is drug related, if you withdraw the drug, patient will have good improvement. And serious causes. All this time, it was not a lung cause itself. So it might be pulmonary edema, which my heart failure. Patient might be having coexisting heart failure. That might be the reason for this disease not to be resolved. Or pulmonary embolism. So you had seen a localized consolidation. You thought it as pneumonia, but it is actually pulmonary infarction due to pulmonary embolism. So this is the causes of non-resolving pneumonia. So they can ask non-resolving pneumonia as a 5-mark question. So if there is 10-mark question, they'll ask mechanisms of HAP-VAP 5 marks and the non-resolving pneumonia 5 marks. So generally community acquired pneumonia is single question 10 marks. Usually the prevention strategies or treatment of HAP-VAP is usually 5 marks only. So they can ask both together, non-resolving pneumonia and mechanisms of HAP-VAP or prevention of HAP-VAP, like that. The host related, organism related, disease related. And non-infectious causes, one by one we have seen. All this time it might have been a malignancy. It might have been a connective tissue disorder, hypersensitivity pneumonitis, eosinophilic pneumonia, organizing pneumonia, alveolar hemorrhage, or drug related or serious causes, pulmonary edema, pulmonary embolism. Now what is the algorithm for identification or diagnosing non-resolving pneumonia? So what all investigation? So another important cause of non-resolving pneumonia can be sarcoidosis. So again, sarcoidosis comes under inflammatory disorders. So what are the diagnostic algorithm? Diagnostic algorithm for evaluating a non-resolving pneumonia. So first thing, you have to assess the patient clinically. You have to see any comorbidity. So is it slowly resolving type because of comorbidities such as malnutrition, diabetes? So you should send sputum for routine organisms and also acid-fast bacilli, fungal staining, and you should give patient adequate antibiotic therapy. So initially, if there is a non-resolving pneumonia, you evaluate the patient clinically. See, are there any host factors? Do proper culture and identify the organism. Identify the antibiotic sensitivity and give antibiotic therapy. If patient improves, there ends the matter. If patient is not improving or the above reports are inconclusive, you have done sputum, gram staining, culture sensitive, fungal staining. Either sputum, patient is unable to expectorate, or in the sputum you have not found any organism or inconclusive. So next go for better sampling. So better sampling from the lung is always bronchoscopy. So go for bronchoscopy and also take biopsy from that area. So if there is some abnormal mucosa, and you ask the pathologist and microbiologist to look for routine and unusual pathogens and also malignant cells. Now if you get a diagnosis here, so you have done bronchoalveolar lavage and you have identified it as some fungus or PCP, or biopsy is suggestive of some malignancy, you treat it accordingly. Now still it is inconclusive. Ball is not showing any organisms. So biopsy is also not showing malignancy, some non-specific inflammation. So then what you should do? So you can go for CT guided FNIC for peripheral lesions. Sometimes if the lesion is very peripheral, you may not get yield through bronchoscopy. So better you go for a CT guided FNIC again to rule out malignancy. And you can go for an echo to see whether it is any heart disease. And to rule out connective tissue disorders, you may need to go for CTD profile. So anti-nuclear antibody, RA factor, ANCA, and if you are suspecting sarcoidosis, you can go for serum ACE levels. So once you do all these investigations, you will get some information, and according to that, you have to diagnose the disease and treat it accordingly. So with this, all these investigations, so you will reach a final diagnosis and you have to treat it. So if there is a connective tissue disorder, either ANA, RA, ANCA will be positive. And sarcoidosis, again, more of clinical diagnosis with biopsy diagnosis and ACE levels. Then if it is eosinophilic pneumonia, in ball you can see. If it is drug related, again non-specific inflammation in biopsy with clinical history. So if it is malignancy, you will find malignant cells. If it is hypersensitivity pneumonitis, again in the biopsy one can see non-caseating granulomas, and in clinical evaluation patient will be exposed to that offending antigen. So if you go through thorough clinical evaluation and step by step sputum investigation, bronchoscopy, blood investigations, you will get a final diagnosis. Accordingly you can treat the disease. So this is regarding non-resolving pneumonia. So we have discussed the definition of non-resolving pneumonia. So we have discussed the etiology of non-resolving pneumonia and how to evaluate non-resolving pneumonia. So what are the initial investigations, what you should do next. So by this we have completed the clinical concepts of pneumonia. So in this pneumonia lecture, so first we have started last week with etiopathogenesis. So then this week we have seen the clinical concepts. So 5 community acquired pneumonia with the algorithm. Then mechanisms of HAP, mechanisms of VAP. Then treatment. So how do you treat? What is MDR pathogen? What is non-MDR pathogen? So MDR pathogen with septic shock, no septic shock. What are the antibiotics to be given? What are the preventive measures of VAP? So then we have concluded with non-resolving pneumonia. So I think we will end this discussion for tonight here. So the next class, it will be completely on COVID and viral pneumonia. So there we will see again the treatment strategies, and I will also discuss the new Indian guidelines. See, again I am saying, so when we are going to discuss COVID, it should be only according to national guidelines, because there are so many drugs. If you start from alphabet A up to Z, there are drugs with some doubtful activity. So all this no need. What is approved by our country, what is approved by US FDA, that I will discuss thoroughly. So thank you and good night, students. Any doubts up to now, you can ask. Antibiotic doses slide I will upload.